Good morning, everyone. Happy Friday the 13th. Um, Hopefully it'll be a good Friday. Um, we're delighted to have Dr. Waldren this morning to talk about AI. Um, my name is Red Schiller. I'm the President for Academic Affairs for the Institute for Family Health and Interim Chair of Family Medicine and Community Health at Mount Sinai. Um, and this is part of our series of grand rounds. Stephen Waldron is the Chief Medical Informatics Officer for the American Academy of Family Medicine, Family Physicians. He received his medical degree from the University of Kansas and completed his family medicine residency at the Wesley Family Practice Residency in Wichita, Kansas. Dr. Waldron has dedicated over 20 years to optimizing primary care through the use of information technology. He started his career focused on the development of technical standards for interoperability, including the ASTM Continuity of Care Record Standard, HL7 Continuity of Care Document, and other technological advances. He also worked to educate primary care physicians on how to adopt electronic health records and how to grow the adoption of family medicine from 5% to over 90%. Dr. Waldron has also helped develop national health IT policy through the work of the Office of National Coordinator, Centers for Medicare and Medicaid, and Medicaid Payment and Access Commission, as well as other national groups and policy initiatives. Currently has been working to evaluate AI solutions in practice that may dramatically reduce administrative burden and the burnout of family physicians. And we are embarking on this. We've sort of dipped more than our toes in the water with this. So this is particularly timely for us and our experience with AI. And we're just delighted that Dr. Waldron, who came back last night from Washington, D.C., and sort of has this little bit of a time lag, but we're delighted to have him. And just a quick reminder to complete the survey at the end of the presentation. Thank you, Dr. Waldron.
Thanks, Dr. Schiller. It's a pleasure to be here and chat with folks today. It would have been nice to be able to be kind of in person, but again, being able to leverage technology here to be able to do these things is great. As we go through the presentation today, I'd ask folks to kind of moderate things. So if you have questions as we go through, they'll stop me if it's kind of a clarifying question. Otherwise, we'll try to spend a good 15 minutes or so at the end to have a conversation. So I'm a family physician by training, although I've been a clinical informaticist now for the last 20 plus years. And I want to talk to you a little bit today about kind of artificial intelligence in primary care. And unfortunately, the crystal ball relative to that is a little bit cloudy, but hopefully we'll give you some kind of insight into kind of where we think this could go and what the Academy is trying to do to drive it to more promise than peril as it relates to the application of AI in family medicine. So first, kind of why is the AAFP kind of trying to take the lead here? And, AI has been kind of the most rapid transformation that's happened, and it's starting to happen now in healthcare. But unfortunately, a lot of times the primary care physicians and family physicians don't have really the input into design deployment of these type of solutions. And what we've seen that happen in the EHR space is that leads to poorly developed and implemented solutions, and we want to make sure that doesn't happen with AI because we still have a lot of those same type of business challenges in healthcare that we had when we created kind of the EMR landscape. And we think that family physicians are unique in the fact that we are very comprehensive in our view and understanding of medicine, and can provide the unique insights that are needed to really make sure that we get the 4 C's of primary care that we know delivers higher quality, lower cost care, such as coordination, comprehensiveness, and coordination, as long as kind of access, which is one of the things that I think a lot of kind of the industry is trying to leverage AI to do, is to be able to improve the access to healthcare. So I thought I would start by talking to make sure that you understand kind of the rate of advancement, or at least as much as we can, because even for me, it's a little bit hard to kind of grasp the rate of advancement that we're seeing. In 2017, this futurist Ray Kurzweil said that artificial intelligence will reach human levels around 2029, and we may actually get there a little bit sooner than that. And then he thought if you follow that out to 2045, that we would probably kind of expand the capability of kind of intelligence, both kind of human and machine together, about a billion fold. So we as humans do a very good job of predicting linear systems. We don't do a very great job of kind of predicting exponential growth. So this is just a slide to try to kind of put that into perspective. So if you look at kind of the literature out there in regards to how fast AI is advancing, anywhere between kind of 110 days to about 7 months. I like using a metric that's used that focuses in on the time that a human would be required to perform that task. How can the AI perform that task? And in that sense, we're seeing the doubling about every 7 months. Although we'll talk a little bit about kind of a new recent development that was launched just earlier this month by Anthropic that kind of shattered that a little bit. But if you think about that every 6 months, kind of doubling a capacity, if you think about when residents start in family medicine and 3 years after that, so when they graduate, AI is going to be 64 times more powerful than it was when you started a residency. And then you go out just one additional year into practice, and at the end of that year, it's going to be 256 times more powerful than it was when you started as a resident. So you'll see things that maybe seem like, oh, that can't happen, or that seems like a toy. It really doesn't really work well. To all of a sudden, like, holy crap, this is something that can almost do something that I didn't think that could have be done, and it almost seems to be kind of magical. Now, if you take that and kind of push that out to that 2045 realm, actually Kurzweil may be off by about 100 billion in regards to the capabilities of the human computer intelligence as a society. So it would end up being about 109 billion times more powerful than it is today. And you think, wow, we can't keep this going for 20 years. I would say that Moore's law, which says that we've been doubling kind of the transistors or the computer capacity every about 18 months, that has been going on for over 50 years. So being able to do this for 20 years, I don't think is that much of a stretch. So I think this technology is going to fundamentally change healthcare and primary care and family medicine. The question is how and how do we direct that moving forward? I just want to make sure that you're also aware of kind of another piece of technology that's kind of related to AI and quantum computing. AI does a great job of managing a lot of data, but it doesn't do a very good job managing when you have to manage a lot of different states. Where quantum computer is the kind of the opposite. It doesn't do a whole lot of great work yet with large volumes of data, but it does a phenomenal job with being able to manage multiple states. And what that means for us in healthcare is that we're able to start to kind of model very complex systems. We're at the point now where we can start to think about modeling kind of protein folding and interactions. Will quickly become to the ability to actually do kind of whole clinical systems or and then be able to look at kind of biological systems such as kind of simulating kind of the activities inside a cell. And it's not a stretch, I think, to think about being able to expand that out to the complexity of potentially the human brain. So again, I don't think you have to think about kind of quantum computing very specific, but know that that's another piece of technology that's going to allow us to see that continued rapid growth in AI. And the great thing there is that if you're able to properly simulate these type of systems, these systems can generate large volumes of data, which is what is needed for AI, and hopefully can address some of the bias and issues that we currently have with our current data sources to drive great kind of AI-based solutions. So in 2019, I said that artificial intelligence will fundamentally transform primary care. The question is when and how. I would say it's kind of faster and more expansive than I thought it was in 2019. And I think quantum computing has the opportunity to expand that even further. And if you look at the rate of kind of advancement, it is exponential also into the kind of the research and understanding that we have in AI. So if you look at the number of articles that are specific to artificial intelligence and primary care, you'll see a significant growth in the number of kind of studies that are out there looking at these things. I think this becomes one of the huge challenges that we have in AI is that, it may take 18 to 36 months to do a study and get the study published. And if we're seeing AI doubling every 6 to 7 months, you can see very quickly how the evidence is going to be very, very stale. And we're starting to see that in the marketplace today. And I'll talk a little bit about that kind of on the administrative application of AI and primary care. So I have a whole series at the AAFP, and I'll give you a link to that a little later on kind of, the terminology and concepts in AI. But I think the core concept that I hope you really start to understand is the different types of AI. And I think when you think about these different categories kind of in practice and what it practically means for a family physician, you can put the AI currently that we have today into three different buckets. So the first is deterministic, and these are things that are kind of rules based. Think about expert systems, and this has been around since the 70s. And the great thing about that technology is it's very easy to understand how the AI is making its decision. And it's also very easy to be able to test every aspect of that AI to know that it's actually accurate and effective. The next layer above that is probabilistic. So this is where we get into the deep learning and the neural networks. Again, this is a little bit more opaque than deterministic systems, but it still has the opportunity to be able to test all the predictions. So if you think about a neural network and how it works, kind of the last layer ends up being a set of kind of artificial neurons. They're going to make a prediction. So say you have an AI system that's trying to predict, is this picture a cat or a dog or neither? It's going to have three neurons at the end of that, and each neuron is going to be able to give you a probability. One, is this the probability this is a dog? The other, the probability is this a cat? And the third is the probability that it's neither a dog or a cat. So now you can think about, testing that system. You can say like, okay, well, let's think about all three of those different, opportunities and the different levels of probability that are given back. And what do we mean? And what do we think about that? And let's test that on real world data. What we've seen the explosion since 2022 is in generative AI. And this is data or AI that kind of learns from extremely large data sets. Think about something that's going to just read everything that's available on the internet. The greatest example of these are called large language models like Gemini, ChatGPT, Anthropic's Claude. And there's hundreds of these models. And these models, all they do is try to predict what's the next appropriate word in an answer. So if you think about how these things are trained, you look through all the data and you create this kind of window and saying, well, if we have these 7 words, what is the most likely 8th word that comes around? The challenge here is that now there's no defined space that you can test because it could be pretty much any word have any probability of showing up there. And then you start to concatenate those words together into paragraphs and now particular long formats. It's just not testable. So what you can do is try to probabilistic, make sure that it's not causing any errors, but you can't guarantee that it's not going to make errors. So while these systems are extremely powerful, there's a risk here on making sure that these systems are actually accurate. And people call that kind of hallucinations as an example, terminology into the workspace. So as you think about these AI, what level is this AI being able to be levered? Is it using generative AI? It's going to have a little bit more of a risk than if it's using deterministic based models underneath. So I think that's kind of the key concept that I hope that you walk out with thinking about kind of AI in that. One thing I did want to say is that the AFP has been working on a set of policies around AI. We released our kind of ethical application of that, and it walks through a set of principles that we think are important. First and foremost, we think that AI needs to preserve and enhance primary care. Again, going back to those 4 C's, that kind of longitudinal relationship. We need to make sure that it maximizes transparency so we can really understand and potentially trust these type of solutions. We have to address the implicit bias that we have in the data. Unfortunately, over the last many decades in healthcare, we've not done a great job of making sure that we eliminate bias out of our application of medicine or practice of medicine. So we don't want AI to be able to learn those bad habits. And we also know that we don't have the diversity of data that we need. And that we need to not only respect the privacy of patients, but also the physicians and others that are using these type of systems. And then we talk about kind of 3 high-level characteristics that we think are important. So one, that these systems need to take a systems view. So it's not about just creating an AI application. It's really about creating a clinical or administrative application that can solve a real problem in family medicine and understand the workflows and the intricacies that we have inside a socio-technical system. And then we think that at some point, AI is going to need to take accountability. We need to have shared liability as we're depending upon these solutions to help us make clinical decisions. And lastly, these systems have to be designed to be trustworthy, because if they're not trustable, they just can't be used in family medicine, in our opinion. So the next thing I wanted to talk a little bit about is kind of the promise and peril. So, AI is just a tool and it can be used for good or bad. And the question becomes, how do we kind of maximize the promise and try to minimize the peril? And when I talk about kind of the peril of AI, I kind of separate that out into what I call external and internal. So external are things that are not necessarily specific to the technology, but really about the healthcare system that we're applying the technology to. And the other is internal. And so these are things that are very specific to the technology itself. So you think about some of these external, perils, the same drivers that we had that created the EMR systems that are, a joy to use, not, are still in place today. And we have the opportunity potentially to kind of automate the same systems that we have in place today and not really transform and really lever the technology. Healthcare is still profit driven, still a lot of fee for service. So it doesn't really align the incentives to really drive high quality, comprehensive primary care. So we need to understand that as well. And we're starting to see AI as being kind of let out to be able to do some medical decision making. And if you're familiar with the new Utah law, but AI is going to be prescribing medications in Utah quite soon. But what's the issue there around kind of the liability and the safety around that? And what does that mean as we continue to think about moving AI from a kind of tool to an actual virtual care team member that has its own kind of scope of practice? And then lastly, we really don't have an effective kind of governance structure to make sure that these things are safe and have a high level of trust. If you think about the current kind of federal administrations, last administration probably had its thumb a little bit more on the side of the scale of safety. This current administration has its thumb a little bit on the side of innovation. Neither one of those are good or bad, but they do mean that the private sector needs to figure out how it's going to probably put its thumb on the other side to kind of balance that out and make sure that we have both innovation and safety moving forward. So what is the academy and what can family medicine do to combat these kind of external perils? Well, we're doing a lot of federal advocacy. We're trying to drive the establishment of safeguards for using AI. We want to make sure that there's liability reform. So if AI is participating in medical decision making, they should also participate in the liability of those decisions. And that we need to make sure that we're promoting the real value of primary care, that kind of four C's that I mentioned, and that kind of longitudinal trust, caring, empathetic relationship we have with our patients. We also are doing a lot of advocacy in the health plans to make sure that we're not only holding them accountable for how they're using AI to maybe drive prior auth denials, but also how are we trying to drive technology on the practice side to be able to combat with those. And then also making sure that there's actual adequate payment for the application of these systems. We also are trying to drive AI developer investor engagement, really to make sure that they understand the value of primary care and family physicians, which I don't think they really truly understand. They know primary care is valuable, but they don't really understand what primary care truly is. And then we need to insist that family physicians are involved in the entire life cycle of AI, from discovery, make sure that we're solving the right problems, all the way to deployment, post-market surveillance. And then, of course, there's going to be an AI research component that needs to be able to be driven. So our kind of philosophy here is that we need to position AAFP and family physicians as leaders in AI so that we're at the table as opposed to being on the table as it relates to these conversations moving forward. On the internal side, I won't talk a little bit about this, but if you have questions, happy to answer any of those. But I think the biggest things to think about is that there's the potential for bias in the application of AI because there's bias in the data used to train that. The other is that there's a lack of generalizability. So just because something, especially on the clinical side, works in one institution doesn't mean it's going to automatically work in the next institution. You really have to make sure that you do the evaluation to make sure it works. Right now, there's kind of a paucity around kind of case law around privacy and copyright. So pretty much think about making sure that you're thinking about informed consent with patients and providers around the technology, that you're thinking about how these systems are able to support privacy, and then understand that AI technology can't be copyrighted. So if you're putting your stuff in and creating content out of that, you need to have a human component to that that allows you to make sure that you have copyright. And also think about anything that you put inside these kind of public models are going to be integrated in and be part of the process of training these systems moving forward. So think about kind of, intellectual property and putting those in, you're kind of giving that away toward these large companies. And then as it comes to the technology itself, we talked about hallucinations a little bit. We kind of alluded to the fact that there's kind of lack of explainability. So we know the answer that AI gave us, but we're not really understanding truly why did it give us that answer. And then we also know that these systems can over time can drift. So both they start to kind of have a different understanding of the models, but also we also know that data itself in healthcare rapidly improves. So you have to make sure these systems continue to be reevaluated and retrained quite often. Otherwise, you'll have stale models that think about as an example of a model that was trained in 2018 for respiratory illness, and you try to deploy that in 2020, it's going to be awful because it does nothing. It knows nothing about COVID-19. And then lastly, we think about kind of the human AI interactions. And the biggest thing there is automation bias. We know that family physicians and other practitioners in healthcare are extremely busy. And it's very easy if you see something work 99 times in a row that you just assume that it's always going to work. And that it can't be the case, especially with generative AI. We need humans to be able to kind of review these things and make sure that we're just not assuming that they're correct. One thing that we talk about in regards to kind of evaluating and oversighting these technologies is that we need a risk-based framework because we want to be able to balance innovation and safety. So there was a model that was created in 2014 around the FDA to try to do that. So as you think about these AI systems, these are things to think about relative to what's the risk of me using this technology with my patients? What's the purpose of the software? Who's the intended users? If it's a patient, it's probably going to be a little bit more risky than if it's a trained physician using the technology. What's the likelihood of hazardous solution arising? Do I have any transparency into the system to know how it kind of created its answer? So these things help you try to think about that model, kind of in regards to risk and using AI. So enough of the kind of a little bit of the kind of the doom and gloom. Let's get to the cool stuff that is the promise of AI that we're seeing currently today, and where we think this may go in the next couple of months. So this is my mental model of how I think about where does AI kind of fit into primary care and family medicine. We spent a whole lot of time on administrative burden reduction because of the epidemic of administrative burden. But we also now being able to apply not only automation, but intelligence to the systems that we have the opportunity here to really reduce the cognitive burden as well. And I've kind of been harping on the 4 Cs, but I think these are things that have to be supported by AI. And then we talk lastly kind of about the notion of the clinical aspect of that, just because of the risks there and the issues when we started doing this work in 2019 that we really had focused on the administrative side. But I think the time is now to start thinking about kind of the clinical application of AI. When I think about the application of AI for family physicians, I try to put AI into one of two buckets. Is this technology expanding the capacity, or is it expanding the capability? So is this something that you're able to do, just not don't have the time to do it, or by leveraging AI, you can do it cheaper, faster, better? That isn't expanding your capacity. In that sense, it's very easy for you to look at the answer that AI gives you and say, is that correct or not correct? As opposed to if it's expanding your capabilities, maybe this is something you could determine if it's correct or not, but it would take a significant amount of time and resources to be able to understand, is that truly right and doing well? So that provides a little bit more risk than if it's thinking about expanding capacity. So again, we've been focusing mostly on the right side of this on kind of burden reduction and capacity building in primary care. But when you get into the clinical side, then you can start thinking about, is this a tool that helps with prevention or screening, or is this helping with diagnostics, or is this actually making you apply the evidence so that you're creating great treatment recommendations, or is this actually helping you engage the patient? Is it actually having a conversation with the patient to collect the data that you need? And data collection hopefully will be something that will be relegated to the AI, something that family docs into the future won't have to do much of, unfortunately, hopefully. So where is kind of AI used currently in family medicine? So this is a survey that we did in 2024 in September. And it showed that, again, kind of that administrative use of technology is kind of where things are at. And then some behavioral health and some clinical decision support was starting to make its way into family medicine. So as we think about administrative tasks, there was some great work done by the folks at the University of Wisconsin around the amount of time physicians were spending inside the EMR. And what we've been focusing on these 4 big key areas. So making sure that we have the ability to do documentation in a more efficient manner, that we're able to do a chart review, how do we kind of manage the inbox? Definitely after the pandemic, that's become a major source of burden and time commitment for primary care physicians. And then lastly, the kind of order entry and billing and coding is important, both from a fee for service, but also from a value-based payment models kind of moving forward. So those are things that we've been kind of focusing in on. So what if you could have your own assistant, or maybe your own kind of chief resident that could kind of pre-round for you, could start pulling stuff together and present it back to you so that you can make kind of your final decision making. And that's where we're seeing the technology currently is available in family medicine today. So I'm sure you guys talked with Dr. Schiller a little bit before the presentation today, and it sounds like you guys are already starting to do the deployment of ambient scribing. But we're also seeing technology that actually is able to provide you with the right kind of technology around the codes that are needed so that you're kind of making sure that you're getting paid for what you're doing, but doing that without have to spend a lot of time and energy. We're also seeing the cognitive burden reduction. So we're seeing technologies that can read through the entire EMR and including a health information exchange and create a problem-oriented summary. So now when you have your diabetic, you're not going to look at the labs and going to look at the scan documents to see if they had an eye exam done, and then back to the labs because you need to see if there was a microalbuminuria, and then you got to go back and say, okay, well, what's their bed list? And now I need to go back and say, well, where this is a patient not of mine, but I'm covering for one of my docs. So what was their plan? So you're kind of spending the time just surfing around the EMR trying to find data. And what we're finding is now that you actually have a problem-oriented summary that's now clinically relevant to the patient at hand, and significantly reducing kind of that pre-visit planning and prep that has to be done. We're also seeing the application of what I call semantic questioning of the chart. So now you don't have to go and say, okay, well, was there a colonoscopy done? Was there anything in the prior colonoscopy that maybe that was done that says that they should be on a more rigorous schedule than every 10 years? Or did this patient have a Cologuard, or did they have a double contrast barium enema? How was that done? You can now just ask the question of what was colon cancer screening status for this particular patient, and the AI is able to understand what that truly means and go and find all that different data and pull that together. We're just starting to see the inbox pieces. We've seen some evidence right now that solutions like Epic, which I know you guys are using, is only focused on creating the response. It's not thinking about what's the clinical problem that's trying to be solved. Again, if we had a lot more family docs involved, they would understand it's like, well, the first thing I need to know is I need you to triage my inbox because I only got 2 minutes and I don't want to open up a message. It's going to take me 20 minutes to do. And now I've wasted my time and I have to go back to unread and that message. And I just do extra work. The next thing is once I do that and open up a message, what's the data that I need to answer that question? So if this patient's asking for a renewal of their diabetic meds, what's their hemoglobin A1C? Do they have a scheduled appointment with me? And what time is that? When was the last time that I saw them? Those are questions that you're going to want to know the answer to make sure to say like, yeah, let's send a message back to this patient that it's really important for them to take their meds, but it's also really important for them to keep their appointment the next 2 weeks. So now it starts to actually create the message that's appropriate for that particular clinical disposition of that message. So we're just starting to see some technology that is able to do that and showing some real great promise in that. And again, we're starting to see a little bit of these kind of chat and voice bots that is able to actually have a conversation with a patient and collect the needed information that's needed, but also being able to generate the type of patient education materials that are very specific to an individual patient. Lastly, I want to talk a little bit about some of the free resources that we have at the AAFP. So I'll just provide you some kind of data that's available. I won't go into this a whole lot because we're getting close to our 45-minute time. But we do have a three series session, each about 30 minutes, that kind of go through kind of what is AI? How do you think about applying AI? It goes in a little bit of understanding of kind of the evaluation of AI. And then it talks about some of the key solutions that are in place. We also just recently created a new CME that's focused around kind of the use cases. So if you think about how do I go about thinking about the application of AI into my practice, this kind of walks you through kind of how to think through that, but also provides you kind of with a catalog of use cases that we're seeing currently in the marketplace. Again, mostly focused around administrative burden reduction, but a couple looking at kind of preventive screening of technology or of patients, excuse me. On the generative side, I did write an article that goes through kind of the pros and cons of using these large language models like ChatGPT, and kind of what those issues are. Again, these are not HIPAA compliant solutions unless you have one that's built purposely for healthcare. So do not put any protected health information, and also don't put any proprietary information from your organization into these tools. And then also understand that every time that you get these responses back, there can be a hallucination. But this kind of goes into a little bit more detail than that. But I think those are the highlights to think about as relating to large language models and family medicine. So the Academy has been trying to drive AI. We created a Starfield Summit in the May of 2025. We brought together about 80 individuals, both from primary care and AI, to think about what should family medicine and primary care look like if it was really strengthened with AI and digital health. So there is a report. It's a 30 pager, so it's a little long. But you can throw that into ChatGPT and ask it for a 4-page or a 2-page summary if you like. But it does provide you kind of a vision and roadmap of where we think AI is likely to hopefully go, or where we want it to go over the short period of time. So we talk about kind of these 5 beacons for effective AI use. It needs to be able to, again, kind of preserve and protect primary care. It needs to really support that kind of longitudinal relationship that we have with patients that we know drives down costs and increased quality. We need to make sure that we understand kind of that human AI shared decision-making component, and how does that work moving into the future? And how do we make sure that we deliver systems that really do help populations? And then make sure that we think about kind of how that AI is going to be fit into the workflow, and what is the research, and how do we affect that research into the application of AI in primary care. So to do that work, we're creating a primary care innovation network. This is kind of hot off the press. So we announced it at our FMX meeting, but still a work in progress. And what we're trying to do is, in essence, make sure that we have this network to bring primary care family physicians together with AI leaders to make sure that we have the right products for family medicine, and that we really have the investment that's needed to drive the solutions that we need in family medicine. And then we also make sure that we are kind of informing kind of the education and advocacy activities of AAFP and other primary care champions to make sure, again, that we're maximizing that promise of these technologies and minimizing the peril. So these are the 5 pillars that we see that will kind of stand up as part of that. So part of that is, AFP and family physicians being at the table, making sure that we're translating that research into effective implementation science so that we can apply these solutions well in family medicine. Make sure that we are really training family physicians. I think the training of family physicians has the potential of going through a really significant transformation over the next couple of years because of the application of AI. Again, hopefully getting back to kind of the real reason a lot of us went into family medicine is to really start to care for patients and think about those kind of complex issues that we have to deal with in humans, but actually be able to use the AI to do all the clerical work, be able to pull data together, to be able to be a true support for us to bring back that joy of medicine. And I think there's a real promise that will actually happen. So we think that this outcomes are being able to bring the physicians and clinicians together, those leaders, to make sure that they really understand primary care and what's needed, and that we have the right technology, and that we actually apply it appropriately in primary care, and that our family physicians are the leaders here, that they really know how to apply this type of new technology, so that we're seen as the future of medicine, and not something to be disintermediated. There are some non-kind of AAP resources that I wanted to list. So the Society of Teachers of Medicine has an AI curriculum. They're in the process of revising that, but it's a modular-based system, thought through kind of what are the competencies that are needed if you're being trained as a family doc. So I encourage you to take a look at that. I've done a little bit of work on Elion Health. I can't recommend it yet because I haven't talked to the leaders of this. But this provides a great kind of market map of what are the types of AI that are being deployed, and what are the companies that are there doing this. So it's a very interesting kind of site. But again, just a word of caution there. I haven't done enough due diligence to know that it's right. But every time that I look at the site, I don't see anything that I disagree with. So it's another great kind of piece. So lastly, here in the last 2 minutes, you want to look into the future. And anytime I do that, I talk about Amara's law. Amara was or was a admiral in the Navy, and his law was that humans underestimate, or excuse me, overestimate what technology can do in the short term, and underestimates what technology can do in the long term. So know that any kind of recommendations I think about or predictions I have in the future are likely to have those biases. But I think we'll see, and we're already seeing seismic changes in the application of AI in family medicine and primary care. We're seeing a lot of promise on administrative burden reduction, cognitive reduction, but we're also seeing the peril of standing up kind of AI solutions that are not tied to longitudinal primary care. And again, I hope to kind of maximize that kind of access without maximizing the other three C's, which have to be done as well. I think AI will not replace us, but it's going to replace some of the tasks that we do. Some of those, I think we're going to be very happy that it actually replaces a lot of those administrative tasks. But I think also there's some real challenges from some edges. Why can't I say that word? Um, I can't say it. But think about kind of fundamentally what is our core value in family medicine, and what are we going to do relative to leveraging AI kind of moving forward. And it's going to say, like, here's some of the tasks that we think are unique to us that unfortunately are not going to be unique to us, and we're going to have to come to deal with those moving forward. Again, I think a lot of the application of AI is going to be human and AI. I would say, though, on I think February the 4th of this year, Anthropic released a new version of their Opus model. And we're now seeing where it can do autonomous tasks up to 2 weeks. We actually also saw where it can actually now do what they call AI swarms, where it actually is able to coordinate multiple instances to do a task, such as being able to have 16 different AI instances working together in concert to create software code that would take humans months and months and months and months to do, is now able to do that in a couple of weeks. And there's another example that model was able to orchestrate the work of 50 knowledge workers in software development. Some of those were AI agents, but a lot of those were humans, and it actually was able to manage that. So this notion of a kind of an autonomous AI is a little bit closer than I thought I was even back in January. So again, I think we'll continue to see these kind of ChatGPT moments where it's all of a sudden we're seeing, that just the explosion of the technology, and agentic AI is what I was mentioning there with the new Claude Opus 4.6 model. So my takeaways for us today is that AI is going to transform healthcare and care delivery and family medicine. AI does reduce burden. We're seeing it reduce administrative burden in the documentation by like 70%, and chart review like 60%. There's still a lot of unknowns. We're going to have to kind of chart our path moving forward with this, but I think we're well positioned to be able to be leaders in that. And if clinicians actually take up that lead, I believe that we'll see a lot more promise with this technology than we will with peril. So I look forward to the conversation that we may have here in the next 15 minutes, or any questions that you might have. So let me see if I can stop the screen here. But before that, my email address is there. Please don't hesitate to reach out. Happy to answer any questions you have kind of moving forward. That's part of the reason that I'm here. So happy to have the conversation.
Thank you, Dr. Waldren. That was certainly a provocative and great summary. A lot of challenges ahead. I'll read some of the questions from our listeners. One question is, do you have any helpful guidelines on how to teach AI in a residence setting while ensuring residents have a strong foundation in medicine and are not reliant on tech? Although I think the reliance on tech, that horse has left the barn, and so. But I think, any guidance on teaching AI, are you aware of models where they do this well? And
Sure. Yeah, so a couple of things. So first, if you're looking at the literature, one of the key buzzwords there is called de-skilling. And that is the notion of, kind of dumbing down individuals because they're using these types of technologies. This is a conversation that's happened since medicine got started. And the latest one, which was about 25 years ago when I started to get into the work of clinical informatics, there's a lot of discussion of clinical decision support. So, for example, renal dosing calculators. Well, if family physicians are being trained in academic centers with these kind of clinical decision support tools, but when they get out into practice, they don't have access to those, is that really an issue? And what some of the studies did was crossover studies of saying, and the kind of the punchline here is that they found that those residents that had access to the tool, but the tool was taken away, actually did better than those that never had access to the tool. So I think as we think about these solutions, make sure that they're actually teaching as well as predicting. So why did it give that prediction? And then I think also we have to think about critically appraising the predictions that we get from these technologies and say, why would this be correct? Why would this be wrong? What do I need to do to make sure that it is correct and not wrong? And I think if we do those type of things, I don't think we'll see the de-skilling because of the AI, just like we didn't see when we had de-skilling because of clinical decision support, or when we had the ability to write down our information into books. We didn't see the de-skilling either. We actually had reskilling to have new skills that we need to be able to lever.
yeah, that reminds me of when many of us were taught in medical school, there was a lot of reliance on recall.
Yeah.
And you were considered a good student if you could remember a bunch of stuff, as opposed to now the expectation is being able to look it up. And I think that's sort of an example of, some
Yeah,
of
that critical thinking is
yeah, exactly.
one part. Yep.
Another question is, will AI chatbots become better at exhibiting caring and compassionate services than rush providers? Maybe even do it better?
So in the current situation, I would say yes, only because we're as humans not given the opportunity of time to be able to do that. There was a recent study that looked at kind of the AI generated responses to inbox messages. And patients felt like the AI was more empathetic than the physicians. And it's like, well, yeah, if you don't give physicians enough time to write a message, they're going to write the short, succinct, terse message that this is what needs to be done because they're just not given the time to do that.
Mhm.
But I do think that, into the future, that kind of empathetic hand on the patient aspect of primary care will be even more valuable than it currently is today. Again, in my opinion, or I guess in my hope.
Yeah, we all hope. Here was a question about cost, especially for safety net providers and independent practitioners. We're certainly aware of the additional costs that EHR has added to the delivery system, not only with the technology, but with the personnel costs, the
Yep.
regulatory compliance. And, I guess that's a real question about the the current model of for-profit medicine and people looking at AI as an opportunity for uh, generating additional profit, again, adding to the additional cost. Any thoughts on
Yeah. Yeah. So
that?
I mean, I think those are real issues. I would quibble a little bit on terminology. So I think the issue is not because we're profit driven. It's because profits are driven because of utilization. Then the sicker and the more we do, the more money we make. Whereas if the profits were really around keeping patients well and healthy, then the incentives are aligned well that it's not an issue. So I think that's the real crux of the issue, not necessarily the profit, although gouging and all those type of things are important. I think one of the challenges that we have in healthcare IT is that we don't have substitutability in the marketplace. So if you guys decided, you know what, Epic is not working for us and it's too costly, it's not like a cell phone where you can move all your data and your number and you
Mhm.
leave the store and nobody sees it differently and you have all the stuff there. So until we have that, we're not going to see a reduction. I think one of the hopes or the real promises here is that a lot of the folks that have been starting to build technology in the AI space and healthcare come from the consumer realm, like the Googles and the Amazons and those folks, and they see technology continue to decrease in cost. And we're starting to see that a little bit with some of the ambient models that were, $3, $4, $500 are now having options that are, $99 per clinician per month. So hopefully that will continue, and they won't get the same type of issues that we see with traditional health IT, where it's just continued to increase in cost, not decrease.
Um, One question I have is, what are the opportunities for innovations in the delivery model? For example, there really is a great opportunity to increase the voice of the patient.
Yep.
And, as we know now with the patient portal, there's a lot more interactive. Any thoughts on sort of how the patient and, in our case, even the patient's family can interact more around and their medical record?
Yeah, so I think one of the challenges has been is what I call context. So when patients would go search and go to Dr. Google and then bring in all this stuff, many times it wasn't relative to that particular patient situation, and or it was really about driving clicks. So, all the snake oil things kind of read up. So they just spent a lot of time debunking and all that kind of stuff. What we're seeing with AI, if you think about a personal chat bot, hopefully one that has been developed in a way that protects patients' privacy, you can now start to ask questions that are in your context. So it's really about your medications, your health history, and being able to write that in a very succinct model. Now you can bring that to the clinician and have an informed conversation. And the clinician's like, oh, well, this is stuff that is actually relevant to you because it's in context of your health care. It's not erroneous information that I have to debunk and go through. So I think there's that kind of opportunity if it's implemented in a correct manner.
Um, few more questions
Oh yeah,
if you can hang in there with us.
yeah.
Do you have any thoughts about the safety net access? Um, Mount Sinai has some embedded enterprise HIPAA compliant AI.
Yeah.
I guess the question is, how do we in FQHCs, get access to some of these? Um,
Relative to that, do you think you guys are on one of the larger, EMR programs? So they're going to be producing a lot more kind of AI solutions moving forward. I do have concerns that they're going to be able to be state of the art. But can they actually create solutions that really do work? Absolutely. And hopefully they can do it in a way that it was cost effective. I think when we talked about being able to deploy these type of technologies in that issue or that situation, there were two issues. One is the demand is so high that when we saw them apply kind of the ambient scribe, all the time savings for the physicians was soaked up in seeing more patients. So there was no burden relief. So the burnout was there. So the docs were like, well, what am I doing here? Because it's not really, it's quote unquote helping me, but it's really not helping me because now I have more work than I had before. Because not only do I have to kind of do all the review of the documentation, but now I have to see more patients. So I think that's an issue. And then the other, as you think about the clinical application of AI, are they actually training these AI solutions on a representative population that you're taking care
Hmm.
of? And unfortunately, a lot of times those populations are not the same. They're more an affluent, white, male, set of data. So I think that's the other challenge that you have to kind of think through. So unfortunately, I don't think I gave you any answers. I gave you two more problems, but I think those are a couple of areas to really focus in on.
Yeah, well, there was another question that sort of follows up on that is this idea of increased efficiency and productivity will lead to increased workload burden,
Yes,
almost like the Charlie Chaplin Modern Times movie where you
faster hamster
speed it
wheel.
faster and faster. And, and I think, is your point, what's our goal here in terms of improving the care of patients and, not just necessarily being more efficient. So,
Yeah. Yeah, I think that's really critical and probably something I should have done a little bit better job on the kind of the governance around kind of AI. But you have to have the right problem set. So when we talk about those, like say, well, if I can save enough time to add 7 patients to a day for a provider, can we add three?
yeah,
So that one, we're actually, addressing the access issue. We're also hopefully addressing some of the revenue issue to offset some of the costs. But at the same time, we're also addressing the burnout that we have with clinicians and managing that appropriately.
right. Um, Dr. Gale, I just wanted to find out if you had any questions or as we approach 9 o'clock. Um, maybe we have time for one more. We are currently using Epic AI Pilot for improving clinical documentation. What do you think about the risk our data will be used to improve product and ultimately replace the need for us as clinicians for much of clinical services, similar to the risk of taxi drivers and automated cars? So, I mean, I guess that gets back to this whole idea of governance and, you know, whose
Yeah.
record is this and who makes these decisions?
Yeah, I mean, I think you can make the assumption that they're going to try to leverage the data that any data they can to create solutions that'll end up making profit. So as long as the fee for service system is to see as many patients as you can, then yes, I think they'll try to do that. I think also there's an opportunity to say, well, what is the real value of the primary care physician? If you look back in history, such as the development of the spreadsheet, there was all this conversation about, oh, we're not gonna need accountants because everybody can, do their own. And what we end up found out was that now that it's a little bit easier to do that forecasting, businesses said like, well, I want a conservative, I want a aggressive, I want all these scenarios. So we end up needing more accountants because not only were they more productive because of the technology, but we had more work for them to do. So, I think again, this notion of, the complex situations that we see ourselves in as family physicians, either that be from disease state or socioeconomic state or the combination thereof, the need to be able to have that trusted relationship because a lot of things that we need to do in healthcare is behavioral modification of the
Mm.
patient so that they have better lives moving forward. Those things I think are still going to need that human touch for the foreseeable future. But I also do believe at some point in time, there will be AI care team agents that will be part of the process, just like we have, physician assistants, nurse practitioners, PA, all those type of folks. will have that same type of capability inside of kind of the AI computer intelligence. And the question begins, how do we transform family medicine to deliver value to our patients and have a great profession? And again, I think there's some great opportunity there for us to do it if we lead.
Yeah, completely agree with you. And that was so. I just want to thank you so much for stimulating and provocative discussion on this topic. And who better than family physicians to lead this? I mean, you know, we should not even just be dealing with our own discipline, but other disciplines, and just the foundation of primary care um, could really be transformed by some of this technology.
Awesome.
So again, thanks for joining us this morning, and we look forward to subsequent presentations on the updates.
Thank you so much. It was a pleasure today. I saw Dr. Nozel got up really early today to join in. I appreciate that. You guys have a great leader there that has been doing just a significant amount of great work and
Yeah,
advocating for family medicine and the values that we represent. So great that she's able to do
she
that, and it's been fun working with her. So thanks so
she
much. And again,
she is a treasure.
yep, you
Thanks.
had my email address. Please, I
Yeah.
mean, if you're a student resident, don't hesitate to reach out. I'd be happy to chat with you if you
Okay.
have any other questions. So thanks again for taking the time
Be
to chat with me today.
be well.
Be well.
Have a good weekend.